Rashna ma'am, can we start?
Yeah, sure.
Swikar, please start here. Dr. Swikar.
I'll be talking about good evening. I'll be talking about zoonotic infections of the head and the face. Contents first we'll discuss what exactly is what do you mean by zoonosis, and then we'll talk about the common conditions which affect the zoonotic infections, which can affect both the head and the face, which consist of a very narrow but very gray area where a lot of conditions are included, but we'll be able to discuss only the common ones. So let us move on to the next slide. So what is zoonosis? Zoonosis is a Greek word which means zoon means animal and osis means illness. So according to the WHO, any disease or infection that is naturally transmissible from vertebrate animals to humans or from humans to animals are termed as zoonotic infections. About 61% of the human pathogens are zoonotic in nature. This is a proper this is image which correctly depicts the zoonotic disease. It can be spreading from uh, humans to animals and with their interaction. Then the older classification used to categorize zoonotic diseases as into four types. That is, if the disease is transmitted from animals to humans, it was called as anthropozoonosis, where the examples were rabies. If the disease was transmitted from humans to animals, then it was called as zooanthroponosis. Examples include TB, tuberculosis in cats and monkeys, which have been reported earlier. Then, if it is both ways, like it is transmitted from human to animals or animals to humans, then it is called as amphizoonosis. It is both ways. So some staph infections are known to be transmitted both ways. Then there are certain diseases like called as zoonosis, where the parasitic diseases they include the parasitic disease where human is an obligate host. So it includes Taenia solium and Taenia sagenita. Uh, if we look at the classification by ecosystem, synanthropic synanthropic zoonotic disease includes those in which the transmission of diseases between humans and animals, where the animals live in close proximity to the humans. That is the domestic animals, the pet animals. Whereas exoanthropic means they are away from the ecosystem of the humans. The, which include various arboviruses, wildlife rabies, and Lyme disease. There is also an etiological classification according to the organism, which includes viral like Ebola, HIV, avian influenza, fungal infections like ringworm, mycoplasma, like Mycoplasma pneumoniae. Uh, then parasitic, which includes trichinosis, malaria, echinococcus, chlamydial psittacosis, and rickettsial bacterial infections like anthrax, salmonellosis, and certain acellular non-viral organisms are also transmissible like spongiform encephalopathies and mad cow disease. Uh, with this in mind, let us go on to the conditions. We'll have a case, then which will be followed by the description of that particular diagnosis. So let us look at the first case. Hello, hello. Am I audible? Hello, 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 hello. Dr. Nitin, hello, hello. 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 Or any. So it could be a discussion. Means if anyone can wants to attempt and like if the guess this Potter. Hello.
You continue presenting.
Yes. So this is basically a case of tinea capitis, where it is a dermatophyte infection, where they infect the keratin and keratinized tissues. It is a fungal infection of scalp and of scalp hair. It is also known as herpes tonsillis infection or ringworm. Three genera of tinea are responsible. It includes trichophyton, microsporum, and epidermophyton. The high-risk groups include HIV, diabetes, prolonged steroid use, and anemics. Uh, Protective factors that prevent there are certain protective mechanisms which prevent the colonization of such organisms. One is the dryness of the skin's outer layer, shedding of outer layers of the dead skin, the innate peptides and the medium chain fatty acids secreted onto the skin. And there are certain factors that increase the likelihood of dermatophyte infection, which is related to the age. The extremes of the age are more prone to have such infections. Immune status of the child, steroid use, diabetes, trauma, and occupational exposures. Then there are certain fungal specific factors and host specific factors which are uh, are responsible for the like this which decide the uh, means decide the what the risk factors, and which include adaptation to a specific host, release of the enzymes, production of inflammatory factors and toxins, and release of immunomodulating agents. Certain host specific factors also, that is site of entry, non-specific defense mechanism, and immune response. Looking at the pathogenesis, once there is inoculation of the arthropoconodium, that is pores to the keratinized tissue, where the carbohydrates microfibrils present on the fungal spores anchor to the keratinocytes. The pores germinate and produce hyphae, which spread centrifugally into the deeper layers of the stratum corneum, and that is responsible for this kind of penetration is responsible for the ringworm, the classical circular shape of the lesion. And invading fungal hyphae then produce various enzymes like keratinases, proteases, and elastases, which invade the stratum corneum. On invasion into the stratum corneum, the digestion of the keratin and other proteins for there is digestion of the keratin and other proteins for the growth of dermatophytes. They develop a specialized structure called as the penetrating organ to invade the hair shafts. The keratinases activate the keratinocytes to release certain immunomodulatory mediators like cytokines and interleukins. which then recruit both the humoral and the cell-mediated immune response, causing various inflammatory processes. Uh, we have already looked at the pathogenesis pathophysiology. So once it has invaded, it can present in three principal ways. Where if the hair shaft is infected, infected from inside, that is the endothrix, such kind of clinic, infection is seen in Trichosporum tonsillas infection. It can be seen as an ectothrix uh, in where it infects where the microconidium is seen in the outer hair sheath. So it is classically seen in Microsporium canis, and whereas a favus is basically a chronic inflammatory kind of process where there is formation of crusts and there are scutula. This is classical of Trichosporum sponoleni uh, infection. The clinical features, it affects mainly prepubertal children between 3 to 14 years of age. Classically, human to human transmission is there, but there is sometimes there is history of pets. Some symptoms which include redness, itching, scale formation, alopecia will be present. It starts with reddish papules, which may increase in size to involve the entire scalp. The skin of the affected area might be normal in the center, but appears irritated, red, inflamed at the edges. The infection may extend to the eyebrows and the eyelashes. You can see classically the involvement of uh, the scalp, and then infection may extend to the eyebrows and the eyelashes. The infection is mainly of two types, that is inflammatory, like the carrion, and non-inflammatory. Uh, Three clinical types of tinea capitis which are seen is, one is black dot, that is a black dot tinea capitis, where there is infection with the fracture of hair, which is seen, it will be seen like black dots over the scalp. Uh, then carrion is basically a lot of inflammation which can cause scarring, alopecia. And favus is the inflammation again and again can cause crusting, deep-seated oozing nodules, scutula and abscesses. This is post carrion, the scarring can cause, like, this is the appearance of the scarring which is there. There's something called as id reaction, that is idiosyncratic reaction, mostly seen after treatment with the antifungal. It may be at a very distant site, like for example it can be in any tinea infection. This infection is over here, but the id reaction is seen in the form of itching, tiny vesicles over the face, erythema. It can occur anywhere. It can occur at a distant site from the primary infection. It is due to the immune reaction to the circulating fungal elements. It may also present as erythema nodosum or annular erythema. Then lab investigations include a specimen which can be collected, can be sent for fungal culture swab, biopsy, or scalp scraping. Most of the times it is a clinical diagnosis only. Still, if you want to understand the organisms, then other useful KOH found can be used to visualize spores and hyphae. Wood lamps examination of the hair shows uh, fluorescence in these various fluorescence, like for example microsporum species shows green to yellow green color fluorescence on examination, which can be performed bedside also. Treatment and management, the systemic antifungals can be used for 4 to 8 weeks. So the point here to be highlighted and taken home is that the only treatment and which is very effective for treatment for this tinea infections is systemic antifungals and not just local application of shampoo. So drug of choice is glycopulmin that orally. In microcrystalline form, the dose is around 20 to 25 milligram per kg per day, and in the ultra micro size form it is 10 to 15 milligram per kg per day. Topical application is not recommended. Also, shaving of head, like most of the parents will ask us whether head shaving will help the child. It is not recommended to do head shaving. Then there is what is the role of steroid, like in certain presentations like carrion, where there is a where there is lot of inflammation has to be controlled. In such conditions, a short dose of low-dose steroids can be used, and it can prevent the like few studies have shown that it has reduced the risk of scarring, alopecia later on, and reduce inflammation. Other options which are FDA approved include oral terbinafine, that is 3 to 6, given at the dose of 3 to 6 milligram per kg per day for 4 to 6 weeks, which is FDA approved only for above 4 years of age. Whereas oral capsule itraconazole, which is non-FDA approved, can be given 3 to 5 milligram per kg per day for 4 to 6 weeks. We have to remember that all the agents which we are giving have to be given for 4 to 8 weeks minimum on an average, for the, because it is very difficult to treat this infection. That too, systemic antifungals have to be given. Vigorous shampooing with certain agents like 2.5% selenium sulfide, zinc, pyrethone, or ketoconazole only reduces the spread of the infection, but will not help in the mainline management. A 17-year-old male presents to the clinic complaining of a blister on his chin. The patient has no other complaints and denies any fever, chills, or jaw pain. His past medical history is significant for type 1 diabetes, uh, well managed on subcutaneous insulin. The examination reveals two blisters, one on his jawline and other beneath his chin. Both these blisters have surrounding both these blisters are surrounding erythema and crusting and swelling. Crusting can be visualized using crusting can be sorry, crusting can be visualized around the hair follicle, and it is noticed that the hair follicle is extremely easy to pull out. Woods lamp examination shows fluorescence. What is the most likely organism responsible? Uh, so So here we are talking about another infection, which is another. It's a dermatophyte only, which is affecting the beard area and the facial hair. It is also called as the barber's itch or beard ringworm. Very rare in children, but more commonly seen in the adolescent age groups. Initially, spread was rampant due to unsanitized razors. Now, a zoophilic transmission has also been seen in the farm and domestic animals. Most commonly positive organisms include Trichophyton verrucosum, Trichophyton mentagrophytes, and rubrum. M. canis is seen among horses, dogs, and cats. Uh, Clinical features includes history of pets, domestic animals, then mainly adolescents and adults. Constitutional symptoms are very rare, like they may not have fever or anything. Two clinical morphologies can be seen. Here also same inflammatory and non-inflammatory. Inflammatory in zoophilic, most likely zoophilic shows unilateral boggy erythematous nodules, and hair becomes lusterless and brittle. Whereas non-inflammatory shows pruriginous, like severe itching, superficial dermatophytosis, uh, diffuse erythematous squamous plaque with perifollicular pustules and papules. This is the image which is showing, and this image can have various diagnoses if we see just as a spotter, which we will discuss later on. Management here also in any TINA infection, systemic antifungals are superior to the local antifungals, and oral terbinafine, azoles, and griseofulmin are commonly used. Duration again is 4 to 6 weeks, and topical application of other agents is not well defined. Then, if we look at the differential diagnosis, once such a patient comes to us in OPD, we should consider a lot of other things in mind, like bacterial folliculitis. So here the history of fever will be much more prominent. Malaise will be there. There might be local lymphadenopathy, which may or may not be there with tinea. Then perioral dermatitis. Uh, then pseudo folliculitis barbae, which is associated with shaving more diffuse, and it will be seen bilaterally. Then contact dermatitis, HSV infection, acne vulgaris. Candida will have, if we consider Candida here, Candida will be having more adjacent mucosal involvement also. So the important part here is to keep in mind the setting in which the patient has come. Like, is the patient immunocompromised or immunocompetent, uh, and all those things. Then, looking at the differentials only, that is, if we see at bacterial folliculitis, it is associated with more constitutional symptoms as we discussed, and hair removal will be very painful. If we consider in tinea barbae infection, hair removal may or may not be very painful. Then, pseudofolliculitis barbae, it is a chronic inflammatory disorder of the follicular and perifollicular skin, where shaving or plucking of the hair precipitates the onset of an inflammatory reaction that results from the penetration of adjacent skin by growing sharp tips, which is more common in adults. Looking at herpes, herpes also looks like is one of the differentials is herpes, where it starts like a fluid-filled blisters, and then it will be having a base of a red swollen skin. Burning sensation and pain will be more pronounced in a herpes infection. Case 3, 17-year-old male, 17-year-old female patient with no significant past medical history presents to the outpatient clinic with complaints of itching of the scalp. Physical examination of the scalp is notable for multiple excoriations, eggs at the base of the hair follicles, and the small insect pictured. What is your diagnosis? What is the following? Which of the following is the best step in the management of this patient? So it is very commonly seen now. So we are talking about pediculosis capitis. Here there is intensely pruritic infestation of the lice in the scalp hair, which which head louse is a obligate parasite that spends its entire life on the human host. They are exclusive blood feeders, size around 2 to 4 millimeters. Most common form of lice, it is the most common form of lice to affect children between 3 to 14 years of age, seen in all socio-economic backgrounds. Girls are more commonly affected than boys. Small outbreaks can occur in school age groups, and it is more seen in the summers and humid climates. The transmission pattern is interesting. The head lice are unable to jump or fly, so hence uh, close contact is required between the two persons. Sharing of a headgear or direct contact with the fomites is common. This is the life cycle of the head lice. This is showing various starting from once the female lays 4 to 8 eggs for the next 16 days and then dies. After that, the lice egg is laid on the hair shaft. After 6 to 7 days, the young louse hatches, and then it goes to the stage of first, second, and third mold. After which the male and the female are differentiated, which lays eggs, and the cycle continues. So this is showing various eggs which are laid, which can be seen in most commonly. This is also another image which is showing various eggs. Rarely we can find a lice also. Pathophysiology, it is a immune mediated, the lice can cause immune mediated hypersensitivity reaction, which takes around 2 to 6 weeks to develop symptoms after first exposure. Pruritus may occur after 1 to 2 days. Means after lice infestation, for the symptoms to develop, it takes around 1 to 2 days. Where the first symptom of pruritus will be occurring after 1 to 2 days. Scratching can lead to secondary bacterial infections after as the barrier is eroded. The histopath is suggestive of sharp edges with an infiltrate of lymphocytes, excoriation marks, and intradermal hemorrhages. Clinical features include the intense pruritus, which is a hallmark. Visualization of at least one louse is diagnostic. Nits, that is, eggs, are not diagnostic of recent infection, as nits can stay for very long periods of time. And dandruff and dust particles may also act as false positives. Lice in one family member means you have to screen for all family members for the same, and they have to be treated together. Uh, Lab evaluation as such, it is a clinical diagnosis only. Some may use sticky tape to get an adult lice for microscopic examination. Woods lab examination may be done. It can show nits. Nits are known to show greenish yellowish fluorescence on Woods lab. Management, we have to first is a wet combing to get rid of the nits, and shaving of the infested areas. It can present as a inanimate they can present as inanimate fomites, heating infested clothing, and bedding with hello.
Please go ahead. We can hear you.
Yeah, uh, yes, ma'am. Shaving of the infested area helps in these cases. It can be present in the bedding and the linen. So, uh, heating infested clothing and bedding with hot water is necessary to destroy all stages of the lice. The heat necessary for destruction of lice and nets is around 52 degrees Celsius for around 30 minutes. Important is to treat all family members. The pharmacological principles which are involved in treatment of lice is first is by neurotoxicity. which causes paralysis of the lungs, and second is the suffocation by topical application. So these treatments may not clear the eggs, and often 7 to 10 days extra treatment is required for resistant lungs. Looking at the various classes of drugs which we have, pyrethroids is the most commonly used treatment for lice. 1% permethrin, which has the mechanism of action is that the sodium transport across the neural membranes causing respiratory paralysis of the arthropods. But recently resistance has been detected. It is still first line due to its good efficacy and the safety profile, and the residual effect is there till 3 weeks. Malathion is 0.3% is used. Organophosphate cholinesterase inhibitor that causes respiratory paralysis in arthropods. It is applied to dry hair until hair and scalp are wet and left on for 12 hours. Second application 7 to 9 days after initial treatment may be necessary. It is important to know that it is a flammable agent and it is not advisable to use in infants and neonates. Then linden, which is 1% linden can be used. It's an organochloride that kills lice by respiratory paralysis. It is absorbed into the blood and slowly metabolized and should not be used repeatedly. It has a potential for neurotoxicity. It should be used, it may be used as a second line agent in adults, but should be avoided in children. Uh, then spinosad, it is not very commonly used. 0.9% concentration is used, where it is used mainly in more than 4 years of age. It was approved in 2011. It works by provoking hyperexcitation causing death by paralysis. Twice the eradication rate of permethrin at 14 days and is effective after a single dose. It may be beneficial for patients not adherent to other therapies. Topical ivermectin, 0.5%. It increases chloride in the muscle cell, causing hyperpolarization and paralysis. It works with single application. Only a small amount of systemic absorption after topical application occurs. However, it should be used as a third line agent due to its limited clinical experience and its cost. Ivermectin has also been used by certain centers, but it is not FDA approved. These are certain drugs used for head lice. Differentials for head lice may include dandruff, seborrhea, superficial fungal infection, eczema, folliculitis, and scabies. Coming to the next case, a 5-month-old boy presented with 1 month history of intensively pruritic scaly rash, characterized by crusting and excoriation over the body and face. Mother was HIV positive, also suffering from itching of palms and shoulders with similar lesions. In spite of the treatment, there was no improvement of the eruption and no relief of itch. A serum immunoglobulin Ig was done, which was found to be normal. So this is the image which is showing the child as well as the mother. So this is a diagnosis of scabies. It is a clinical diagnosis only. It is a contagious skin condition resulting from infestation of a mite, uh, Sarcoptes scabi, where it forms burrows within the skin and causes severe itching. Misdiagnosis is very common. It mainly affects the hands and foot in adults, but in infants and younger children, it can affect the face and the neck areas extensively. Uh, Looking at the transmission, they lie in the dermal and the epidermal of the layer of the skin in humans and animals. The transmission occurs via skin-to-skin contact in minimum of 10 minutes required, via fomites, bed sheets, via pets and domestic animals. Looking at how it enters into the skin, the adult females deposit eggs as they burrow within the skin. The eggs will hatch, releasing larvae. Larvae will molt into nymphs. Larvae and nymphs are found in short burrows called as molting pouches, and the mating occurs after the male penetrates the molting pouch of the adult female. Uh, the eggs can cause more. Eggs are responsible for causing more itching than the burrowing. This is a classical burrow of scabies which is seen. Clinical features: serpiginous white lines indicating mite burrowing are classical are pathognomonic of scabies. Infants and children may not show these classical findings. It is a type 1 hypersensitivity reaction. Type 1 hypersensitivity reactions to the mite, eggs, or excrement may occur, forming erythematous papules. Scratching, encrustation, and possible impetition can occur. Incident areas involved include the face, skin, and the trunk. In infants, bullae and fistula are also seen. Fistulas are also seen. The eruption may include wheals, papules, vesicles, and superimposed eczematous dermatitis. The another variant or more serious variant is the crested or Norwegian scabies. Uh, it is highly contagious variant of scabies, which is seen mainly in immunocompromised infants or infants born to diabetic, born to HIV mother, uh, where it is characterized by profuse proliferation of mites in the skin and widespread crested hyperkeratotic papules, nodules, and plaques. Management permethrin, that is Elmite 5%, can be applied to the entire body from the neck down on affected areas. Cream is typically applied once a week for 2 weeks, that is total of 2 treatments. Children less than 2 years old, mostly face, scalp, and neck are affected. So lotion is left on or over the face scalp for 8 to 12 hours and reapplied after 1 week in a similar fashion. Other agents like linden 1% solution, sulfur ointment, and chromatin lotion are also used, but which are not very effective. In case of immunocompromised patients and severe infestations, a dose of oral ivermectin, that is 200 microgram per kg per dose, given orally for 2 doses, 2 weeks apart, also is recommended. Then treatment of family members is very, very important. Treatment of bedding, linen, and clothes with hot water. With hot water is important, and they have to be dried. Transmission is unlikely after 24 hours after treatment. Itching persists due to hypersensitivity. If pruritus occurs for more than 2 weeks after treatment and the new lesions are occurring, the patient should be re-examined for the mites and the treatment considered for a retreatment. Nodules are extremely resistant to treatment and take a longer time to be treated. Might require multiple applications. Moving on to the next case. Then 8-month-old infant comes with complaints of pruritic lesions over the face, scalp, and trunk, sparing the diaper area. Child is very irritable. Mother says the child is having on and off symptoms since 4 months of age. No fever. Father suffer from asthma on inhalers. Lesions show below what are the lesions are as given at the site. Diagnosis is this is not a zoonotic condition, but it is a very close mimic of what all conditions we have discussed. So I just put a slide for that. That is atopic dermatitis. It is the most common chronic inflammatory skin condition. The chronic disorder associated with pruritus usually starts in infancy and presents with dry skin, eczematous lesions, and lichenification. It is associated with IgE associated disorders like allergic rhinitis, bronchial asthma, and food allergy. It is characterized classical atopic march includes atopic dermatitis, allergic rhinitis, and bronchial asthma. The pathophysiology here is a defective skin barrier that is susceptible to xerosis and environmental irritants and allergens. There are two forms of it can occur via IgE mediated, which is the most common and seen in majority of the cases, whereas it can be non-IgE mediated also. Both of them have eosinophilia. The circulating T cells expressing the skin homing receptor, cutaneous lymphocyte associated antigen, produces cytokines to activate the T helper 2 pathway. uh, Also, there are genetic alterations which are found due to loss of function mutations of the filaggrin gene, an epidermal protein that is broken down into natural moisturizing factor. So the pathogenesis consists of three main factors. That is, three main factors, which includes first is epidermal barrier dysfunction, second is immunological abnormalities, and third is aggravating factors. All of this in various permutations and combinations are associated with atopic dermatitis. Uh, th- there's a table which enumerates the major features and associated features. I will just go through the major features, which includes pruritus, facial and extensor eczema in infants and children, flexural eczema in adolescents, and chronic or relapsing dermatitis. Personal and family history of atopic disease. Other features can include xerosis, non-specific dermatitis of the feet, uh, white dermatographism and delayed blanch response, elevated serum IgE levels, early age Denny lines, Denny Morgan intraorbital fluid may be seen, facial erythema or pallor. Uh, this can have a relapsing and chronic course in infants and children. This is the classical atopic dermatitis lesions which are there, crusting and which can mimic any of the fungal infections. The management consists of four components mainly, that is trigger avoidance. Secondly is daily skincare, skin hydration. And third is anti-inflammatory therapy, which includes topical as well as systemic therapy and other complementary modalities. So the take-home message here is clinical history and thorough examination paves the way to diagnosis. One particular condition can have several mimics. It is important to understand the setting and various factors like whether the patient is immunocompromised or any underlying other disorders or other comorbidities are there to rule out the differential. Examination of specimens bedside under the microscope is of great value in certain conditions like using a Wood's lamp or like most of the times it is a spotter which is very easy to diagnose. And scalp and face lesions can give various clues to various systemic conditions. Thank you. Hello.
Yes. So this is the end of your presentation. You can stop sharing your screen.